Action.
Action, right? Thank you, Joe. Anyhow, this is a Thanksgiving Eve edition of Nursing 101. What finer topic to talk about than bowel and bladder. And the rest and digest parasympathetic nervous system, right? That's what you're going to do. You're going to eat all that turkey and you're going to rest and digest, right?
Yeah.
Right?
Yeah.
You're going to try and talk that.
What's in turkey? What's that neurotransmitter that's part of the sympathetic nervous system in the brain? What are those three in the brain? The serotonin, right? Isn't that it?
Serotonin and
Dopamine and GABA, right? Those three, but that's all right. I'm not. There's a lot of information here, and it serves and it needs to serve as a background to understanding bowel and bladder. Okay? You've got your packets in front of you, right? I'm going to step over here to the computer and there'll be some blank. And okay, so in bowel and bladder, you've got on your blackboard. Let's just start with the bowel, shall we? I gave you in your packet, okay, and the people at home that are looking at the movie don't have the advantage of the blank packet unless people know somebody. Anyway, but these are the answers to what you have. So like I know ulcer isn't necessarily a prime topic. I did talk about bismuth, which is used sometimes in ulcer, treating an ulcer. And we'll talk about that when it comes to it. But you see, I have answers here for you on the sheets that I've given you. Let me just go through just to show you real quick. In red, you've got the answer keys to all of this stuff. Okay. So I'm not telling you that you have to go home and kill yourself looking at this stuff. In terms of the test, you have to review, and we're going to review it. But this is great background stuff, and in lieu of having a nice, solid thing in this topic, okay? And these are from pharmacy books. Not actually Keys. Who do you use? Lilly. It's actually from another one, and I'm sorry to say that to you, but nevertheless, they're bona fide, and it's a learning experience for you on your own. Okay, so that's that. I give you a GI coloring page in terms of anatomy of the GI tract. And what is the GI tract? We call it a tube within a tube. Have you ever heard of that? Isn't that cute?
From the mouth.
Yeah, from the mouth to the anus, right? And then you got the body, so a tube within a tube. So I think what you have in the back of your thing, you have this on the back of your. Oh, I actually. I actually gave you the answer key. There you go. You have the key, and then you have the blank, so you can fill that in for your anatomy. And let's see, which one is this? I have a better one. Oh yeah, okay, no, this is right out of your book.
which book?
Well, I don't know which book. It might be out of it might I don't know. I'm sorry. Through the years, it's been a lot of different books. But it's bowel disorder drugs. It's a PowerPoint on it. Again, I'm telling you some of the drugs that I want you to know, but nevertheless, you just take some time and go through them kind of passively. It won't, it'll be all right for you. Okay, now this is the Craven. We're going to look at this PowerPoint. Okay, I've got the same one. This is a little thing, maladies in the stomach. You can look at it. Let's go ahead with this PowerPoint about the stomach and about the GI system. And then we're going to look at this virtually the same thing when it comes to looking at the GU system, okay? I hate to do this lecture style. I don't really want to do it, but again, you have blanks, a lot of fill-ins in your PowerPoint. So it is participation in that sense. You're writing things out as we go. If you don't catch it, that's okay because it's on Blackboard, okay? You can always go back and look at it, all right? So just to start things off to tell you that. And I kind of got to fly. You know what I'm saying? We got a lot to do. So I like questions. I do. But let's just kind of go through, and if there's time at the end, we'll cover those. And I got email, and it's a long weekend, and you know, I was eating turkey and resting in relaxation. No, I'm doing lots of things. True or false? Digestion begins when food reaches the stomach.
False.
Is that false? Okay, where does it start?
No.
What's that enzyme?
Amylase.
Amylase. Right? An external sphincter is a smooth muscle that is under involuntary control.
That's false.
Right? What is that? What are we referring to? What do you call me?
I don't call it.
Okay. Yes, the anus. Okay? Stool produced from ileostomy is liquid and contains large amounts of qualities of the electrolytes, right? Of course that's true. That's where all that digestion takes place. We know that from anatomy, right? The small intestine. But if you got an ileostomy, sometimes those things leak. You know, you got the leakage around them. Have anybody experienced some of that perhaps? And it's very irritating to the skin, much more than just like a regular colostomy that's in one of the other areas of the large colon. Okay, you got to understand where it's coming from in the body. This is the small intestine, a lot of enzyme, a lot of liquid, okay? Very irritating to the skin, just to tell you that. Normal intestinal flora inhibits the growth of C. diff. Clostridium, yeah, absolutely, right. That's like the garden, the flowers inhibit the weeds, right? C. diff is what? Kind of like a, they call it an opportunistic pathogen. Opportunistic pathogen, right? Hey, 1, 2, 3. You're late. Bring back one of Rebecca's here, okay? And parasympathetic stimulation slows peristalsis, right? Is that right? No. Yes. No. Just the opposite. Rest and digest. Okay, let's get into that just a wee bit, okay? And we'll talk more about it as we go. We'll introduce it slowly. We talked about what's that main neurotransmitter with the sympathetic nervous system that gives us that fight or flight. What do you say? Epinephrine, adrenaline. It goes by a few names, okay? The main neurotransmitter in the parasympathetic is, oh, come on, some of you looking at me. Acetylcholine? ACH, is that right? Right? Okay, acetylcholine. You have, let's do this real quick, okay? And I'm going to go through it real quick. You have the brain here. You have the spinal cord, correct? Let's say, okay, what happens? Well, and then you have the bowel over here, squiggly little bowel. And you have the bladder, okay, with the urines, okay, with the kidneys, right? All right? With the kidneys, right? Okay. All right. Then you have a stretch in the bowel. The bowel stretches and stimulates, okay, the walls to stimulate peristalsis, so it moves along. But what stimulates the bowel? What innervates the bowel? You have nerves, all right? And they go into the spinal cord, up through the spinal cord. Some of them go right back to the bowel. This is called an arc. This is called an arc. Some of them come here and go right back to the bowel. Other ones start here and go all the way up to the brain. Right? So when you got to defecate, your brain overrides the arc. So you got a colon full of poop, stool, and it's stretching the bowel, and it's saying, man, I got to go to the bathroom. Your brain's able to control it, right? You got a spinal cord injury, guess what? If you're lucky, you still got the arc. If you're lucky, you still got the arc. Because then we could put suppositories in there. That'll stretch. They use even CO2 suppositories. You've ever heard of those? You put it in water and it fizzes. Okay, it's like the fizzy drinks. Put them in there and it fizzes and bubbles up. Those are horrible to use. I don't like them myself. but they fill up the bowel and cause the bowel to poop. I'm talking about a bowel program where you've got a paraplegic patient that needs to have a bowel movement every day. So we want to stimulate the bowel, so we're going to take advantage of the arc. So we give them a suppository that then goes to the arc and the bowel, and he poops. You see? You're taking advantage of this arc. Some patients have what they call lower motor neuron disease, where the arc doesn't work. The arc doesn't work for the bowel. So when you get your patients down from the 3rd floor to the 2nd floor, and you're going to work in there, and you're doing your assessment, and you take your gloved hand, right, and you check for impaction, you check the stool, so you check the rectum, and you stick it in the rectum. Guess what? It doesn't hug your finger. It doesn't hug your finger, right? Like the rectum should. Stick your finger in your butt, it hugs your finger, right? These people don't hug their finger. Loose. Loose. Lower motor neuron disease, okay? And so, not disease, it's lower motor neuron. And what happens is you then, and we're going to talk a little bit further as we go, but again, this is background for the stuff we have to talk about. Now, acetylcholine, now we're going to talk about the innervation of acetylcholine. Acetylcholine's effect on the bowel is to make it contract. There's receptors on the bowel, and they receive. So you have acetylcholine. I don't know. I'm no artist, and I'm nobody's.
Picasso?
Can you move that? Is that picking this up? Just move it a little bit. Yeah. I'm nobody's pathophys teacher either. Okay, but the acetylcholine will be sent out. Here it is here, acetylcholine, and it goes to the muscle. Say it goes to the other communicating cell, be it the muscle or another nerve cell, and it will make for smooth muscle, it'll make it contract. So when you're relaxing, you're sending out acetylcholine, and acetylcholine is, if it's properly being channeled through the nerves, etc., will help the bowel contract. So that's why it's rest and relaxation. It also helps the bladder contract. So you defecate and urinate. That's acetylcholine's effect on smooth muscle. It makes it contract. There's a lot more to it. We're going to talk more about it as we go, but that's the baseline of it. Is that good?
Yes.
Okay. All right, we can move it just a little bit over again if you don't mind. So, and we'll talk more about that as we go. Peristalsis is that movement that we talked about. That's what you're listening to when you listen to your bowel sounds, correct? Or your patient's bowel sounds, I should say. Right? That's what you're listening to. What is it when you don't hear any peristalsis? What's that word? What is it? It is hypoactive, but you're still hearing it. Okay, if you listen for 5 minutes per section and you haven't heard any sounds, it's called paralytic ileus. Paralytic ileus. You've heard of paralytic ileus? I know you have, because I've said it right out of these lips. And when you have paralytic ileus, what do you think happens to that poor individual? Remember Eddie Murphy and Shrek? They're walking up the mountain. I know you're eking out gas, right? You're just eking out all that gas, right? He wasn't far from the truth. That's what we do. You have to eke out that gas. Otherwise, if the bowel's not moving, your belly starts to swell up. What's treated with what? How? Okay, you just talked about it in lab this week. Last week. NG tube. Decompress. Come on, I'm seeing a couple of smiles out there. It's not new. You're not connecting the dots, folks. And you know what? You're too far along in the game not to start connecting these dots. NG tube. Oh, decompression. Right? They put it down an NG tube for decompression. Okay, I don't know if you talked about sub pumps, did you? Okay, but they go onto a pump. They put on low suction intermittent suction. They pump out the gas, or if they're pumping out fluid in the stomach that they have to get out, okay? Decompressing it. So that's what they have to do. So if you get a patient with paralytic ileus, you're going to make sure they probably have an NG tube. Okay, hemorrhoids, okay. Hemorrhoids, of course, are varicose veins around the anus, right? If they pop while the person's on the toilet, it looks like they chopped off an arm or something. You know, it makes the water very bloody. And as a nursing student, I want you not to freak out too much about it, okay? It does make the water very red and very bloody, okay? But it could just be a hemorrhoid. It's not like they're bleeding to death. But it's an interesting, it is interesting. You can see people like, oh my God, all that blood. They are treated. This reminds me of something you want to tell a person who has hemorrhoidal surgery. They'll do rubber bands, or they'll burn them off, or however they'll do them, I don't know. But afterwards, I do know this, you don't want them to do what? Same thing with cardiac patients.
Right.
Push. You don't want to do that, what's that V word?
Valsalva.
Valsalva. You don't want them to do that Valsalva movement. You don't want them to push too hard. You ruin that surgery, open up them hemorrhoids, right? And you know, so here is the portion of the intestine brought through the abdominal wall. So stoma, we're going to talk a little bit about stomas and colostomies. Stoma is a hole into the bowel, right? I don't want to be apolitical here, but I always remember it this way: down with the left, up with the right, right?
Right.
Down with the left, up with, so the stool's going down. So this is going to be what kind of stool? You hear the patient's got a stoma on his left, a colostomy on his right and left side, you know he's got what kind of stool? Probably a formed stool, formed turds, as it were. Transverses, more what? Mushy, right? And then down here is going to be more liquid, yeah? The right side is going to be more liquid. As opposed to the ileostomy, which is really liquid and like almost mucousy. Constipation, you know, constipation is kind of like pain. You know, if a person says they're constipated, I guess they're constipated, right? Our red flag is 3 days, no BM, right? Listen. Just as it comes to my mind, know the difference, or I mean, not necessarily for the test, but in practice. Don't chart, when you're documenting that somebody's constipated, be sure not to chart impacted. Have you heard of that before? Yeah. Somebody's impacted, that means that stool's up there like the Rock of Gibraltar, okay? And you know, they have to get admitted for that, okay? They'll knock them out under general, and they'll go up there and get it, or whatever they have to do, okay? Right? That'll bring the state into the nursing homes. Did you know that? Yes. Yeah. If your nursing home sends somebody out with a diagnosis of impaction, you can think that the state might come in for it. Oh yes, I think they will. Because why? Somebody's not checking these students, these residents for impact for. You know, they have to have a bowel board up there, and a good nursing unit will have a bowel board. Every patient in that unit had a BM today. I know because here's my board, and it's all, you know. So when you're charting, I'm just saying it to you, okay? And again, you know, a lot of what I tell you isn't necessarily tested on, okay? But you will be tested in life on it. See? Georgia?
Yes.
Incontinence is yes, somebody's incontinent bowel. You know, they have an incontinent bowel, and they're in. I like the word involuntary. 3, 2, 1. You're late. Audrey. Veronica? Audrey. Okay. She even has her ID out. Oh, shit. I like the word involuntary for stool. In my view, I say he's involuntary of stool and incontinent of urine. That's the way I sort of play it out like that in my head. It's just me. You can say he's fecal incontinent. Okay, whatever you want. So we know that motility refers to that peristalsis. Absorption, you know, the electrolytes and the fluid and our nutrition. We talked about the glucose and all the good stuff last week about all the absorption, medication absorption. And of course, the bowel itself in terms of the colon, the defecation. Characteristics of normal bowel. Now, I think I'm going off of Blackboard, so I probably won't get it right. That's what I thought. This is at Bristol. This is, yeah, the poop chart. Where's Bristol? The Bristol Stool Form Scale. This is used in England, you know, because they're so proper, you know, and they don't want the, you know, they find it easier, I guess, to talk to patients about a subject that is sometimes not, you know, appropriate. I don't know, but whatever. But they use this. We really don't use it. But I thought it was interesting to demonstrate the different kinds of poop. And to talk about briefly, as I, again, in terms of background, and not that I'm going to be testing it out, but you really need to know, I think, as background, when you're taking care of somebody with that lower motor neuron, where the patient has to be taught, or your family member has to be taught, or you as a nurse has to do, take your gloved hand and actually go in there twice a day and remove stool. Go in where? Patient's rectum. Well, I'm going to tell you something. It's a lot easier to remove that kind of stool than this kind of stool. Okay? All right? It's like chocolate pudding. It's like emptying out chocolate pudding. It's like, oh my God, yuck. It's never ending. You know, you see the fecal tubes they put in people, but I don't know if that works with these people. There's no peristalsis going on. It's that arc is wiped out. So you have to consider the diet of these people and making sure that they're making the right kind of stool. You know, that kind of thing. Yes?
How do you deal with a vagal impulse?
Okay.
When you stick your finger out there, you touch the vagus nerve and it will drop the heart rate.
Well, I don't know. I just, you monitor the blood pressure. Probably would be the best way I can tell you. Monitor the vital signs. And don't be so difficult with it. I mean, in terms of, don't be so aggressive with it. Perhaps take it easy. Be safe. That goes with removing constipated stool as well. You know that the lady who's screaming next to you in the cubicle in ER? Oh, that's probably having a stool. Yeah, I'm not trying to be funny. I mean, it's quite the reality of it. So that's how it goes. Okay. So there's your anatomy again. I'm not going to. It's at least some room people's anatomy in here. Yes. Okay. So in which of the following organs does the process of digestion begin? We talked about that. The mouth. Amylase.
Yes.
I didn't probably put these on the report. Lifespan considerations. I did put this on your form, I think, but I didn't put the rest of this on there. Oh wait, no, this is for stool. I did it. The first stool is for infants called meconium. Have you heard that before?
Yes.
And if they're born with it swallowing, ingesting meconium, it's a problem. And it's dark and tarry, because it's again the same black and tarry stool that the patient will have if they're ingesting their own blood. So if they got a bleeding ulcer in their stomach, how does the stool come out? Kind of meconium-like, right? Black and tarry. This is a telltale sign, very classic of, okay, you knew that? Yes.
I have a daughter, so I know about meconium.
You have an infant daughter.
Yes.
Brand new infant daughter.
9 months.
And you're the lucky chap that gets to clean it up?
I was.
Very good. Toddler, so toddlers start on the toilet, you know, potty training, right? At that age. What do we call that in toilet training? We call it people who have very strict toilet training. They say they have what psychologically? They're anal retentive. Have you heard of that before? Obsessive? Obsessive compulsive? What?
Edison State.
Joseph, I'm not getting it, but, okay. Talk to me later.
Erickson stage.
Yeah, that's what he said.
What's his name?
Erickson stage.
Erickson stage of autonomy versus shame and doubt. Good for you. Autonomy versus shame and doubt. Yeah. Right. So they're going to be doing it themselves, and then of course the school age developing bowel elimination habits. They start, and adults risk for constipation. Older adults, they don't drink a lot of water. If somebody says they drink a cup of water, is that enough water in the day? No, you got to know that as a nurse. Some people won't click. Nurses, it clicks. Some people, it doesn't. How much water do we take? CCs, please. How much water a day should people be drinking? Or fluids, but water's that's
Shouldn't it be
nuts.
1,500 to 2,000?
Yeah, I like the high end, 2,000, yeah. Uh-huh.
1,500.
Oh, 2,000 is on the question.
So factors affecting bowel elimination. Okay. Nutrition, of course, we've talked about. Fiber is very important. We've talked about that. We've talked about the two different kinds. Yes.
So when you're pushing the fluids, how much is that?
Another 500, 2,500. And I'm telling you this in terms of NCLEX questionings. Because they'll talk about, they'll put that in as a distractor and it'll be like, oh wait, that's not enough water. You have to, remember you have to read each response. You really have to read these questions, folks. Read each response. Is this good? Did I answer your
Yeah,
question?
I was just wondering, because when you were teaching us before, you said 2,000 was when you push. Right, you said.
Okay, 1,500 to 2,000 would be, I'd probably take 2,000. Maybe a bigger person, 2,000, the average person, maybe more like 1,500. It's variable, a lot of variables. Between 1,500 and 2,000 would be a normal amount of fluid in. You start pushing, it'd be 2,500, something like that. Yes?
1,500 is bare minimum.
Let's say that.
That's the bottom.
1,500 would be the bare minimum for anybody
To survive.
to survive. Right? Got it. Okay. Can you get that much out of a cactus or something if you're in the desert?
So you would take a lot more, you would take a lot more.
I don't know. Okay, fiber, and definitely if you need food, you need water with fiber, and consequently, incidentally, if you're introducing fiber into a diet, you also want to make sure that you're increasing the water a little bit, making sure they're taking enough water. That's a big thing. But you can ruin it. You can get them constipated if you give them too much fiber and not enough water, right? Make sure they get enough water. And remember the different kinds of fiber. There's the water-soluble fiber, which brings in water into the bowel, and then there's like fiber, like is non-water soluble that brings bulk, gives the poop something to push up against. Remember that? There's lactose intolerance people. They have a little milk and they get diarrhea, gluten. What's that disease? Celiac disease. They have to buy gluten-free food all the time. It was hard to find years ago. Now it's all over the place. Internet,
Everything is made
gluten-free, yeah. Well,
Supposedly.
could have been a lot of us were undiagnosed with it, but I don't know. They had some people, and again, it's a matter of degree. Some people are extremely sensitive to it, very sensitive to it, and some people, can tolerate it more or less. So, fluid intake, again, I have 2,000 here, so okay. So, and remember, a lot of the poop is water, a lot of water in the stool. Activity and exercise. I can't tell you, I cannot express to you my personal belief. I told you I do this elliptical, right? Man, I'm up there and all of a sudden, wonderful, it's great. It's running, exercise, a nice walk, a little while after you let the food digest, and then a good walk. I'm telling you, you won't be having heartburn. Any young people out there having heartburn? You know what? And we talked about this, Carla. I know. You got it. Exercise is king, nutrition is queen, and together you have a healthy kingdom. Okay? Truly. And it really means a lot to get up and do that. You don't have to take your Tums. Body position. Gravity is our friend. So when you get these patients up on their bedpans, raise that head of the bed. But don't forget them. I've admitted patients nice around their butt, a whole nice little beautiful outline in broken skin from a bedpan. Okay? So, ignoring the urge to defecate, again, leads to hemorrhoids, leads to constipation, leads to impaction. Some people, I have one toilet and one toilet only that I poop in. That's my toilet at home. Thank you very much. Some people are like this.
No, it's a lot of people like
They
that.
will not poop at a gas station. They will not poop in a mall.
Can you blame them?
Let it go. Let it go. Right?
Don't say that.
Like Frozen. Okay. And the when, where, and how lifestyle patterns, once again, high, what's that word for, we want to push his lifestyle, we want to push the high wellness, high wellness models, the prevention, I eat right, I exercise, I do all this good stuff rather than wait to sit around and wait to get sick. Pregnancy, of course, the lady prone to constipation, and what's that drug that they're often put on?
Constipation?
For what that could lead to constipation. Prenatal pregnancy, pre-baby ladies. Iron, iron. They get put on iron, and usually if they put on iron, they're also given a stool softener. God, you guys have babies in here? Maybe not. Maybe I don't have. I used to have. Maybe I don't have a lot of moms in here. Okay. Antibiotics, we know as a rule of thumb can cause diarrhea. We know narcotics can cause what? Constipation. I say narcotic, you say constipation, please. Barium, what do you think barium is? Barium is like a white chocolate. It's like a white chalky shake. Yeah, you drink it before you go through certain kinds of x-rays. And it'll light up. And what you're going for is a GI series. They'll have you drink the barium if you're going to look at the stomach and the front part of the GI tract, and they'll give you an enema, a barium enema, if you're going to go on the lower GI tract. It's an important scheduling thing. You want to make sure you schedule the lower GI first and then the upper GI. Remember your role as a nurse, in case you're a manager, that's part of your role as a manager to make sure they get these tests right. You do one first or the other, it can spoil the testing. Colightly, there's a drug called Golightly, Colightly. That is not the generic term. I actually put the generic term on a rewrite of the, I don't know if you visited the website since I put up the review, but I put up a slightly revised review on Blackboard. It's slightly revised, and although I don't think I put that on there now. But anyhow, I'll put it on. I want you to know the generic term for this, and I'm not going to venture to say it right now. We'll talk about it. And then surgery can slow motility. They open up the guy's stomach and they're going to run the bowel. You're going to take his hand and feel the bowel. Put his it screws it up. It'll be many days before that bowel starts to move again, right? So you can get them back with definitely an NG tube, because they've got paralytic ileus going on, right? Okay, fecal diversions. When I say fecal diversion, this is a fecal diversion. Colostomy. This is a colostomy here. What are the colostomies supposed to look like when they're nice? They come back from surgery and they got a brand new colostomy hanging out of their stomach. What's it look like? Moist, red, and maybe more than pink. Red, little bloody, big, wet, sloppy. But over time, it shrinks down to a nice little, what's the word? Well, that's all too. Stoma, but it's a rosebud. Rosebud. They call it a rosebud. That's what it calls it. That's what it looks like. The good ones. A bad one that's getting lack of oxygen, what do you think it's turning color-wise? Blue and purple and yucky, yeah, dusky. dusky. So these you want to make sure you eye up when you're making your rounds and somebody's got a colostomy. Just take a look at the colostomy. Make sure it's, doing good, got a good blood supply. These are more pictures of a colostomy. Now let me ask you something. Again, we already talked about it, right? We talked about the mushy and the, okay, because that's something to know. Okay. Are all colostomies permanent? No. Somebody with Crohn's disease, for instance, they have an episode and they'll give them a colostomy to rest the bowel. They want to rest the bowel for a while. And then they'll go back and anastomose. They call it anastomose. Put them together again. No, I'm not going to spell it. So one of the following sentences true or false. Sitting sub-squatting position is the most advantageous position for defecation.
True.
In Europe, they've got toilets that are a hole in the ground. You know that, right?
Yeah.
Go to a public toilet in Italy, a hole in the ground. Some of the older cities, Interesting. Not just Europe, probably the rest of the world. So constipation, this is a hybrid PowerPoint. I kind of throw stuff together from other places too, sort of make it interesting, not all what you read. So constipation is criteria. I think it's more or less less. If you say you're constipated, there's a nursing diagnosis called perception of constipation. The person thinks they're constipated. But again, our flag is 3 days. Hard stool is in the rectum, not just hard, but really rock hard. And it needs they might have to have some sort of anesthesia or something to get it out. Liquid stool around the impaction. Now let me talk about that for a second. When you're, this is say, problem too. You've got a cross section of the bowel, and you got stool all impacted here. This is all stool, hard stool, or really it's more probably it's probably here right in the middle actually. Kind of bears a hole right here, surrounded by hard stool. So the patient could be having diarrhea, but really the problem is a severe impaction going on. And when this leaks out, the bowel sounds are particular. They sound like tinkle, 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 tinkle. Yeah, have you been into a cave before? Have you ever been in a cave and you hear far away, you hear the echo of the tinkle, tinkle, tinkle? That's kind of what the bowel sounds like. And it's tinkle, tinkle, tinkle around these boulders here. Boulders of stool, right? As it leaks out. So that's that. Or they just don't attend to it, children in particular, they're playing that computer game and they're not bothering to get off of it to go to the bathroom. Before you know it, they're pooping in their pants. Anybody have that experience? No? With the little ones? I did. Was I the only one that had that? Not my kids. Nephew. It doesn't matter. Functional issues, flatulence. Okay, well, we know what that is. When you're eating a lot, talking a lot, you swallow a lot of air.
Yeah.
What did one burp say to the other burp? Let's be stinkers and go out the other end. Okay. So, all kinds of foods will give you gas, right? Sauerkraut, what else? No, it doesn't give you gas? Onions. What does it for you?
Eggs.
Eggs.
Cheese.
Cheese. We've got the cheese. We've got the cheese. Huh?
Broccoli.
Broccoli is known to do that. Yes, sir. He always comes up with the keen answers. Distension, abdominal distension from an over. So again, you know what distension is. All right. Vocabulary is very important. You know these words. All right. So you want to know them. You want to know when was your last bowel movement. That's a very, very important question. We're not just asking it for our health. risk for identification, not only when the last bowel movement was, but was it a good one? You know, sometimes one little piece isn't enough, right? Okay. Risk of risk identify. What are some associated risks regarding bowel issues? Ooh, what do you mean by that?
Dehydration.
You know,
Right.
the hydration issues,
Malnutrition and, right? It could be kidney filtration and.
what are you talking about?
Right? So it's for bowel issues, but it could be the.
Oh, yeah, the water.
So what are you saying?
I was saying it would be like dehydration would be one, malnutrition would be the other,
And kidney function.
and kidney function.
Kidney function. Also, I think it's also the act of, we talked about it, being careful. If you're gonna be doing a digital stim, we talked about stimulating the vagus nerve. That's the risk. And Rebecca pointed it out earlier, okay? So you wanna, when you're doing your assessment, one of the risks is, you know, stimulating the vagus nerve, perforating a bowel perhaps, if you're giving an enema or something like that. So those are some risks that you have to watch out for. Again, you should know about this bowel inspection. Auscultation comes second. Might be palpation, might be third. I don't know. Perhaps I had that backwards. And percussion. Be the nurse that shines in terms of being the one to say, hey, let's take an abdominal girth of this patient. Okay. If you have somebody with that, we've talked about ascites before, right? The swollen stomach. If you have somebody with a paralytic bowel, make sure you measure the girth. Be the nurse that says, hey, let's do that. Let's add that to the care plan. Because a lot of nurses leave that out. I'm just going to tell you that. Also, when you're assessing a patient perirectal examination, you're assessing for excoriation. Again, if they've had incontinent stool, that skin could look emaciated and red and raw and bleeding. Hemorrhoids, of course, and bleeding, anything that you see there, anything that you know. What's this bowel sound here called? Borborygmy? Or borborygmy? What does that sound?
Like growling?
Like a large sound, a gargling, a large, loud gurgling, like I'm hungry, like the hungry one. All right. So diagnostic stool specimens, okay? What's that magic number when I talked about getting specimens?
3.
3. A lot of times they want 3. They'll say, give me a stool for occult blood times 3. So that means you take it from 3 different specimens, right? Have you anybody ever done the stool for occult blood yet?
Yeah.
You've done it in your work?
Yeah, I had a patient with C. diff, so they was trying to determine whether or not.
And really, what is it? It's just a,
It's like a dab, you smear it.
yeah, it's a card. It's just a card like this. And you know what the advent calendars are? You open up the little door, and you take your stick of stool, and you smear it on here, and then you flip it over, and then you drop medication on where you put it.
On top of this.
On top of the stool. You put the drops right on top of the stool.
And they got a control center on the side.
Okay, there's a control center on the side now? Okay. And what color does it turn if it's positive for blood? Dark blue, or blue, turns blue. So it's just a little stool smear, and you put there's a combination of medicine, and it turns blue. That's positive for occult blood. Occult means what? Hidden. You can't see it, but you can with this medicine. There's also ovum parasites, ovum like eggs, ovum and parasites like bugs, like worms. They look for eggs and worms inside the stool. You get that sometimes times 3. Okay, we talked about GI bleeding, okay, in terms of ulcers. We talked about this before. If somebody's under a lot of stress, and when you go into a hospital, you are under stress. A lot of times it started on these prophylactic anti-ulcer, right? PPI pills. But the idea of having stress in the stomach and having a stress ulcer is very real, so they want to prevent that. And when you have an upper problem like that and you're bleeding, again, the stool comes out black and tarry. We've already talked about that. Stool cultures, again, they'll be looking for bacteria in that in the stool, C. diff, etc. All right. Bowel preps, again, that's that medicine called lightly. Bowel preps to clean out the bowels. If you're going for upper GI or a lower GI in particular, they're going to have you take enemas perhaps, or just drink a whole gallon of this medicine called Colightly. Is it a Colytely or Go with a G? I've seen them both though. There's actually both out there. And it's hell trying to get these older people to drink it all, believe me. A lot of it is a drink. A colonoscopy, I guess you know what that is. They go up the rectum with a scope. An EGD, gastroduodenoscopy, that they go down the throat. They do
Go all the way down into the what?
all through the duodenum, yeah. So it's quite the
Expensive.
it's quite the extensive thing, but they send people all in the name of finding ulcers or, God forbid, tumors. You know. Okay. 3, 2, 1. You're late. Can I have you sit back there because I got the recording? Take some. Is that both of them? Yeah. Oh, there you go. See how we look after our friends. That's wonderful, really. All right, we'll talk more as we go. So nursing diagnosis, not to breeze over these things, but we talked about them enough. Constipation, perceived constipation, the risk for constipation, elderly, right, don't drink enough water. Remember that acronym I've got? Self, schedule, exercise, liquid, and food, or fiber. Okay? So this is how you start a bowel program. Think about those 3 or 4 things. What is the patient's schedule? And when we give suppositories or we want to try to have them poop, we have them do it when? After meals, because it takes advantage of that what? Gastric reflex. Not reflux. Reflux is, it comes up on you, right? Gastric reflex. The baby has a little bit of food and then poops. That's what we do too. You eat, you poop. If you're working right. Schedule exercise. You know, I've got this patient laying in bed, complete bed rest. The only time they actually pass gas is when I go when they're immovable. Then they're farting. Exercise. We just got done talking about the benefit of digestion and exercise. Risk for constipation we talked about. And diarrhea, if they have diarrhea for some reason, very loose stool, above, who knows why they have it, and antibiotics. And then bowel incontinence, of course, is losing their stool. Okay. Outcomes. Patient will demonstrate a normal pattern. Again, patient will be free of preventable complications. And again, these aren't the most measurable ways of expressing these. You can find better ways to measure these when you put them into outcomes. Patient will maintain and promote an acceptable pattern of bowel elimination, but maybe patient will state, you know, that's what you know what I'm saying? These aren't written great. These should have more measurability to them. But, and then the diet, fluids, again, we're going to make sure that we implement the self when we talk about implementation. Laxatives, anti-diarrheal agents, and anti-flatulence agents, okay? Those are some medications. What's the danger of laxatives, though, may I ask you? Things that will make them poop. Seneca, and Cascara, some other drugs. What? Dehydration, they can lose too much poop. You know, just like any drug, you can overdo it. The danger is that they get addicted to these things. Some people got to have an enema. The only time they poop is when they get an enema. You know, and that's the thing, we don't want that, we don't wanna promote that. So people do get addicted to their laxatives. So we really wanna pay attention to that, and that's a red flag if they say, you know, I really like this laxative, I wanna keep it, okay, well, be careful with it, because you do get addicted to those things. Enemas, let's start with the large volume, the HHH, what is HHS? It's a royism, excuse me, but it's hot, high, and hell of a lot. Okay, hot, high, hell of a lot. Okay, but it's not really. It's warm. Okay, warm water, but you got about 3-liter bag. You got these big bags. Okay, you hold it about 18 inches above the patient. You take the lubricated tube, you put it in the lower end of the rectum, and they lay on what side? Left side in the Sims position, and you give them like these liters, as much water as they can take. A lot of times it's ordered enemas still clear. Tap water, enema to clear. You take it out of the tap water. Sometimes you put a little soap in it, okay? But put it in after you put the water in. Little container of what they call Castile soap, liquid. Why soap? Gonna clean out the bowel? That way it's a clean bowel? No, what it does is irritate that wall of the bowel to get that arc reflex going. It irritates the wall of the bowel. Little soap suds enema. They've got small volume ones. Fleets is a very famous brand, and we use that all the time. They have isotonic. So, see, the problem with tap water is it robs the body of all those electrolytes. All those electrolytes leaves the person very weak. We have isotonic solution. The electrolytes more or less stay in the body. Right? So that makes sense, right? We talked about that last week. Again, a lot of background stuff. See how it has to fit into the puzzle? It's not all just nice to know. You have to know these things because it's a background for what you need to know. Fleets enemas also, there's regular ones, and then there's oil retention ones that makes the stool more soft, makes hard stool more soft. That's why, there's oil in it. Return flows are, I think, that's kind of like, you put the water in, you take the water out, A lot of times we do like an irrigation, like you put the tube in it, but the poor little lady can't hold it all, or man, they can't hold all that water. And as you're putting the tube in, these chunks of poop are coming up. You've done this? You've seen it. It's like, oh, these chunks of poop. Just leave it. Just keep it going. Just kind of like keep irrigating. They're not holding it. And the patient's tolerating it. Of course, it's the patient's response you have to look at. But if they're handling it, oh God, you guys are in for so much fun. Really, Flexi-Seal tube we talked about. We used to put those in and have to take them out, put them in, take them out. Now they put them in and leave them in. Correct?
Yep.
Yeah. We used to have to put them in like every shift. Removal of impaction, once again, I said, and I call it an impaction. I probably shouldn't. I should say constipated stool, but don't chart impaction, really. I'm going to tell you. Don't chart it, just say constipated stool. Bowel training, stool softeners, Vocalax, gastric response, so all the stuff we talked about. I'm going to gloss over some of this. We talked about the stoma, what it looks like. We already talked about that already. Stoma irrigation. Okay, I'm not going to go into all of that. Stoma irrigation, you can guess what that is. You take the enema and you stick it in the stoma. You take the tube of water and you put it into the hole. Stoma irrigation. Okay. Home care, make sure that when they go home that they have access to their toilets. Some of these old houses have a toilet in the bathroom way on the second floor, something like that. So you want to make sure you get something close to them, commodes, things like that. And whoever's going to help them. Okay. If we take a break, it needs to be very fast. So if you want to take a break, please, go ahead. You need a break. Take 5. And we'll go ahead and hit this real quick. How do I hit this here?